Welcome to Don't Give Up on Testicular Cancer, a podcast where testicular cancer survivors, caregivers, and others who have navigated the cancer journey share their stories. The podcast comes to you from the Max Mallory Foundation, a nonprofit family foundation focused on educating about testicular cancer in honor and in memory of Max Mallory, who died in 2016 at the young age of 22 from testicular cancer. Had he survived, Max wanted to help young adults with cancer. This podcast helps meet that goal. Here now is your host, Joyce Lofstrom, Max's mom and a young adult cancer survivor.
Hi, this is Joyce, and with me today is Scott Capozza, PT, MSPT. He's a board-certified physical therapist who specializes in oncology at Yale Cancer Center. He was diagnosed with testicular cancer while in graduate school at age 22, which is about more than 20 years ago. And in an article I read about him, he wrote, quote, "Suddenly I had to schedule an orchiectomy, a retroperitoneal lymph node dissection, and 2 cycles of chemotherapy around lectures, laboratory work, and practical exams." Scott shares his experiences with testicular cancer then and now, along with what he's doing supporting cancer patients and survivors through physical therapy. So thanks for joining me, Scott.
Thank you for having me, Joyce.
So let's start, and just before we get into your testicular cancer story, tell us a little bit about what you do as a physical therapist who specializes in oncology. I really think that's interesting and relevant to all of our listeners.
So it's interesting because when I graduated from Ithaca College with my physical therapy degree, over 25 years ago, oncology physical therapy wasn't really a thing. So even if I wanted to go into that profession, that branch of physical therapy, it really wasn't a thing because 25, 30 years ago, oncologists were telling their patients, don't move, don't exercise. Exercise was actually contraindicated back then, and now thankfully we've had years of research that has shown the benefits of exercise. First, in the survivorship phase, to help people recover from their treatments and also to live healthy lifestyles, to prevent secondary cancers and to mitigate cancer-related fatigue and all of those types of things. And the research has continued to move upstream. And so then there was a lot of work done with individuals who were in the middle of active treatment, understanding that patients can exercise and should exercise when they're getting chemotherapy, when they're getting radiation therapy, because again, it can mitigate cancer-related fatigue, helps to maintain their function and really their independence while they're in the middle of treatment. And now we're even seeing on the what I would call the prehab side of things, that first stage when individuals are first diagnosed with cancer, if you have an opportunity to work with them before surgery, then you have an opportunity to get them stronger, and that's going to help improve their post-surgical outcomes and their outcomes as they move forward. But that wasn't a thing 25, 30 years ago. So honestly, when I graduated from physical therapy school, I went into pediatric oncology, or pediatrics rather. My last clinical rotation was a school system outside of Washington, D.C., and when I was done, I said, well, you're going to pay me to play with kids? Sure, I'll do that. And again, the board certification in oncology wasn't even developed yet. I mean, it was being worked on, but it wasn't developed. And the board certification in physical therapy through the American Physical Therapy Association didn't come about until 2019. It took years to develop it. And so I realized that in my work in the adult cancer survivorship clinic that I work with here at Yale Cancer Center, I would see these patients in survivorship and I would assess them. Your range of motion is still a little affected by radiation, or you still have neuropathy in your feet, so you probably need physical therapy. And I was referring out.
Yeah. Oh, okay. Good.
because we didn't have a dedicated physical therapist within our network that we could refer these patients to. We had great lymphedema therapists, but that's only a subset of oncology rehab. That's not the neuropathy, and that's not the deconditioning and all the other adverse effects that we see from treatment. I kind of started down this path of, well, I'm a physical therapist and I'm also a survivor, and I can actually maybe combine these two things together and make that into my profession. When that certification was first offered to us as physical therapists in 2019, I was part of that first cohort that sat for it
Mm.
and took the exam. I was among 68 newly minted PTs in the whole country. I was the only one in the state of Connecticut. There was only three in New England that took that exam and passed it. And so then I used that when I jumped from working in pediatrics to working in oncology full time. When I went to the providers at Yale Cancer Hospital and I said, I'm board certified in oncology. I want you to start sending me your patients. And because of the board certification, they recognized that that was an extra step,
Right.
that I had done extensive studying and training to increase my knowledge base of working with individuals with cancer. And so that's where I am now. I was Smilow Cancer Hospital's first dedicated physical therapist just for oncology rehab. I've continued to work in a multidisciplinary survivorship clinic, and now because of the caseload that I've developed and the relationships that I've created with these providers over the years, we were able to hire a second board certified physical
Mm.
therapist this
Well,
past
yeah.
summer. Yeah, and so we're really hoping to continue to expand that because there's such a need
Yeah.
for physical therapy and rehab for these patients.
I think that's just fascinating to think about how your profession changed over those, 20 years with the need for the specialty that you have now. It's also really positive that the medical profession has recognized that, or your profession. So
Mhm.
that's great. Well, tell us about your testicular cancer story. And you were stage 2 when you were diagnosed. You were in grad school. So tell us about it.
And like many other young men who are diagnosed with testicular cancer, I didn't really fit the bill, so to speak. I
Mhm.
was 22 and I was a runner. I
Okay.
ran competitively at the high school level and at the collegiate
Mm.
level. So I ran cross country in the fall. I ran indoor track in the winter. I ran outdoor track in the spring. I had just run my first marathon 1 month before being diagnosed with
Mm.
testicular cancer. And I didn't drink and I didn't smoke and I didn't do drugs. Also didn't have a family history
Right.
of cancer, specifically testicular cancer, but cancer in general. So I didn't check any of those boxes. So I never would have thought that I would be the one that would get diagnosed with
Right.
testicular cancer. But that's what happened. I noticed a lump in my scrotum, and again, like many men, kind of wrote it off and put it off, especially
Yeah.
because I was in grad school.
Yeah.
I didn't have time to go to the doctor. I was also, like many young adults, I was away at school. I was 6 hours from home.
Okay.
So I wasn't near my primary care physician. I wasn't near my parents. And so it had to have been on me to figure that out on my own as a 22-year-old in a city that's 6 hours from home. So, but the symptoms got so to the point where I had to walk to the health center at the university, and I reluctantly told the nurse there because I had never mentioned any of this, not even to
Right.
my roommate at that
Yeah.
point. And she said, "You're going to the hospital right now." So I went to the hospital and they did a biopsy and they did the blood work and they did the chest X-ray and the ultrasound, and lo and behold, I am diagnosed with testicular cancer. And Joyce, I distinctly remember that it was a Friday night, and the urologist came in and he gave me the diagnosis. And my first response to him, again, classic young adult response, I can't deal with this right now because I have finals on Monday and Tuesday.
Yeah. Right. I get that. Yeah.
And then after that, I am doing an internship as part of my program, one of the best sports medicine clinics here in the city. So I don't have time to deal with this right now. How about I deal with this over winter break?
Oh, okay. And what did he say? Or
He
she?
said he said if you don't deal with this, it will kill you.
Oh, wow. Okay.
And so all of a sudden at 22, I'm, facing my own mortality there. You hear this so often with other young men with testicular cancer, the juggling of school, and now
Mm,
all of a sudden all of these medical appointments. I had to have the orchiectomy when finals were done. I was able to do my clinical, but I had to tell my instructor, all I told him was that I had a surgery and I couldn't do any heavy lifting. I didn't want to go into the details. I was
right.
still struggling with the diagnosis. I didn't want to tell anybody that I didn't need to tell.
Right. Right.
And because I had waited so long, my tumor markers didn't come down, which necessitated the second surgery, the retroperitoneal lymph node dissection. And I had a lot of complications from that surgery. And so instead of that being a 5 to 7 day stay in the hospital, I was in the hospital for a month.
Oh my gosh, Scott, really? Oh boy. Oh,
I lost over 20 pounds. I was on complete bed rest for 2 weeks. So again, as a runner, as a former
um,
athlete, I lost all that muscle mass. And and again, at that time, I'm still struggling with I'm in my last year of my program. Like
right.
I'm so close to getting my master's and being done. I am calling the dean of my school and I'm apologizing for missing class. I finally had to tell him, and he said, "Don't you apologize. We will figure this out." But, there was never a time that I wanted to be in lab
Right.
or to take an exam than when I was on bed rest for
Yeah.
all that time. So get out of the hospital, and I came to an agreement with my doctors. I said I need to catch up on work. It's really important to me that I, try to finish as much of my didactic as I can.
Hmm.
So I was able to postpone chemotherapy a couple of months until I was able to finish the academic aspect of my program. And then when my classmates all went off on their last clinical rotation, that's when I came home finally, and I got my chemotherapy at my hometown hospital, so that way I was living with my parents, my grandparents were there, my hometown friends were there, and so that's where I got my chemotherapy. Ithaca was great in that they just pushed my clinical back 3 months so that I could finish chemo and be done with that.
Right.
So.
Wow.
So yeah, this last year of my program, I had the diagnosis and the treatment all woven into that as well. So in that 12-month span, I did my master's program and I did treatment for testicular cancer.
So I was going to ask you, and you kind of hinted at it, who was your support group through all of this? Because that's a lot back and forth with school and cancer and treatment
Hmm.
and
Yeah. So my parents came up when I had surgery. Thankfully, there was a Ronald McDonald House
okay,
that
yeah.
was associated with the hospital up in Rochester, New York. And even though I wasn't technically pediatrics anymore, they allowed my parents to stay there for the time. So that was great.
Um,
Again, my classmates were great. I tell this story all the time, Joyce, again, to talk about the difference of where we were back then with rehab and where we
mhm.
are now. In those 4 weeks that I was in the hospital, for that 1 month that I was in the hospital, never once did they put a PT referral in for me.
Not once. Okay.
So it was my friends, it was my classmates when they came to visit me. They're the ones that got me up out of bed and they said, "We need to get you walking."
That is so interesting.
I distinctly remember my friend Marissa came one day and she was appalled that none of my doctors had put in a PT referral. She went out into the hall. She was looking for a walker. She couldn't find a walker and she said, "Forget it. I'm just going to take you for a walk." We grabbed my IV pole and I held onto the IV pole with one hand. I held onto her arm the other side, and we just went for a walk down the hall. And that was my physical therapy. It was my friend and classmate that did that. So yes, my classmates stood by me. They supported me. My buddies from school, they stayed with me. They were great in the sense that they treated me normally.
Right.
again, this whole idea of being normal
Right.
and, not wanting to be treated like a cancer patient when my immune system allowed, we would still go out to bars and we went out to ball games and we did all the things that 23-year-old guys are supposed to do.
Right.
And they didn't care that I was bald and, had to wear a hat everywhere I went. They just said, you know, let's go
Yeah.
do it.
Yeah.
And so that was my support group. My friends would come down to visit me on the weekends when I was getting chemotherapy from school. So I really was fortunate in some ways that I was still in school at that time because I
Right.
had my close-knit community. We'd been together for 4.5, 5 years. So I was very fortunate that
Yeah.
I had
Yeah.
my friends from school.
Yeah, it is. I mean, my friends have always been a huge support for me throughout my life, good times and challenging times. So
Hmm.
I wanted you to talk a little bit about fertility issues and what you experienced and kind of any advice that you might have for other survivors who might face similar challenges with fertility. Anything you are comfortable sharing.
Yeah. I will say that I'm very fortunate that my surgeon, the one that performed the retroperitoneal lymph node dissection, he was an oncology surgeon, and so he had done this procedure before, and so he knew the risks to fertility
Yeah.
going into it, and so he did tell me. He said there is the chance the nerve that controls ejaculation could be sacrificed or damaged in this surgery. So if you ever want to potentially have a family, you need to do sperm banking before. And he said, I'm going to give you 3 or 4 weeks. And, I'm 22. I did not have a girlfriend. Having a family was the last thing on my radar at this point, again, with trying to juggle school
Right.
and the cancer diagnosis. But because he brought it up and he recommended it to me, I was able to do that. I was able to do the sperm banking for 3 weeks leading up to the surgery, which I'm grateful I did because there was damage to the nerves. And then I had chemotherapy after that, and that affected the
Mm.
sperm count as well. So it's kind of this double whammy. When my wife and I got married and we decided it was time to start family planning, we did try to use that. We had several unsuccessful attempts,
Mm.
unfortunately. So we went through all of everything that had been banked to get our son, our older son, but we knew that we wanted to have more children. And so the fertility clinic that I worked with at Yale, they were great. We worked with this one doctor who said, well, there's another way that we can try to get sperm out of you. And so they were able to collect it from a different method. And so it did give me hope that we would still have a possibility of increase the size of our family.
Yeah.
And it worked. We ended up with twins.
Okay, good.
So, but my advice would be, this is for any young adult, but obviously especially
Mm.
for your audience. So for anybody who's newly diagnosed, to have that conversation, especially if chemotherapy or, more extensive surgery is on the horizon. If the young man has an orchiectomy and that's the end of treatment, they don't have any other treatment, then we know that the other
Mm.
testicle is viable and can still produce sperm, and that's fine. It's the chemotherapy, it's the other surgeries where you run that risk.
Right.
Everybody has a different risk stratification that they have to talk through with their doctor. And then I would say on the survivorship side of things, like if somebody did not have that opportunity to sperm bank ahead of time, maybe their treatment plan changed in the middle
Right.
to work with your fertility clinic. We went to two different fertility clinics here in the state of Connecticut. We interviewed essentially,
Right. Right.
the program at Yale and also the program at UConn. So because we wanted to see what our options were. And at
Yeah.
that time, Yale offered us more opportunities. They were also in our insurance network, so
Right. Right.
that's a whole other thing right there. There are different options and possibilities.
Right.
Do your due diligence and interview different fertility clinics, a hospital-based fertility clinic, maybe a private practice fertility clinic, just to get a sense of what are your options before you make that decision,
Okay.
because it's a major decision.
It is. And I think what you said at the beginning that your surgeon gave you 3 or 4 weeks to bank sperm. I think not every young man has that time frame. You know what I mean?
Mhm.
My son had a couple hours. It's nice to have that amount of time,
Mhm.
but I also think it's good to know there are other options. So
Mhm.
that's great. I wanted to go back to your running because you mentioned that you were a runner. And So when you got through all of this, could you or do you run or exercise, or how did that turn out?
So I had to basically train myself because, again, I had no guidance. So
Yeah.
having been a runner and being a physical therapist, I figured out, especially in chemo, I figured out the days that I would feel good
Okay.
after
Yeah.
chemo. So
Yeah.
I would go for a run. And I figured out really quickly after that first cycle of chemo, the days that I was not going to feel good. Those are the days that I would not go for a run. But I needed it just as much mentally as I did physically. That's how I identified myself. That was my release. That was an opportunity for me to feel like I was me
Right.
and for me to feel that I was beating the cancer. So just as much as I needed to go for a run physically for all the cardiovascular benefits, I needed it mentally and emotionally to get through that. And so that's why, again, what I do professionally now, it's so important that I try to emphasize that with my patients. It's not just the physical, like building your muscle or keeping your heart strong. It's the emotional aspect of it. It's the mental aspect. It's that ability to have some autonomy back.
Right. Right. That's so important. Yeah.
I ran whenever I could through treatment. And then I was able to kind of rebuild myself after treatment. And I was able to get back into marathoning. And I was able to run a few marathons, actually, and half marathons after that. I had a period where I was doing pretty well. And then kind of the late effects of the bleomyelitis started to kick in. And so I don't have the same capacity to run that I used to. I've switched over to cycling because it's not as much of a stress on the
Right.
cardiovascular system. When I was in treatment, I definitely went for a run whenever I could because it was just part of who I was.
Well, I think you bring up a really interesting point too about our emotional or mental health, how important that is, as well as all the physical stuff.
Yeah, and I think that that is especially for young men. I think that that is glossed over. There's the stigma that we're guys and we're supposed to be tough and all
Yeah.
that. Cancer is cancer. Cancer is tough for
Right.
everybody, regardless of age and regardless of gender.
Right.
Joyce, you probably have heard this before. I was in the chemo room and the social worker came over, all good intentions, and said, "We have this support group. It would be great if you could join it." And I looked around the chemo room, and I'm the youngest one in the chemo room by 30 years.
Yeah. Yeah. I know. Yeah.
These folks they've already had their kids. They have mortgages. Like they're probably
Right.
closer to retirement than they are to
Right.
starting their careers. I'm trying to start my career.
Yeah.
So I don't have anything in common with them. So I didn't have that, emotional support. So I had to have some sort of emotional release. And so that was running. That was also my friends, my non-cancer friends,
Right. Right.
because again, they treated me normally and they didn't see me as Scott the cancer patient. They saw me just as Scott. And so that's what I needed mentally also was to not be treated like a porcelain doll, like something that's fragile, that something's going to break. I just needed to be treated like you would normally treat me.
Yeah. That's great. Just again, thinking of friends and how the important role that they play in keeping us
Hmm.
going throughout our lives. It's so important. You mentioned earlier too, and I don't know if this is something you want to or can talk about, but the genetics of cancer and that you didn't fit the bill on that. And I'll just make a quick personal comment. I'm adopted in my birth family. I've learned my birth mother and all her sisters, except one, had cancer. So I do fit the bill, but what can you talk about with genetics and cancer and just that topic?
It's interesting you should ask me that because, like I said, I was really the first in my immediate family to get diagnosed with cancer. And I honestly feel like I was the first domino to fall.
Yeah.
Because almost 5 years to the day that I was diagnosed, my younger brother was also diagnosed with testicular cancer.
Oh, really? Oh, Scott. Oh my. Okay.
I'll come back to that in a second. But then after that, our paternal uncle was diagnosed with prostate cancer. And then a few years after that, our father was diagnosed with prostate cancer.
Okay. Oh my. All right.
Because my brother and I were siblings now, and we're both testicular cancer survivors, back years ago, NIH was, the National Institute of Health was actually running a study to see if there was a genetic link for testicular cancer.
Okay.
They found the BRCA genes
Or,
for breast cancer,
yeah.
and so there was a researcher down there. I think I found it through Livestrong that this researcher was trying to see if there was a genetic link, and so you needed to be either brothers or like first male
Yeah.
cousins to qualify. So not a big sample size,
Mm.
but still very important. So I have to say, like, it was very impressive going to NIH and just
Yeah.
seeing the research that's being done there, walking through that facility, saying, wow, there's some really amazing things that are going on here. But unfortunately, the study closed before their grant ended, but the grant ended and before they could finish it because they just couldn't get enough of the numbers. But the way that one of the researchers explained genetics to me while we were there was that
Mhm.
if you can
Okay. Yeah.
if you can see
Okay.
my
Yeah.
cup.
Yeah. Yeah. I do. Okay. Very nice.
So so everybody is born with some level of risk.
Okay.
And so some people are born with a little bit of risk. And so they might be exposed to some environmental toxins. Their diet may not be great. Maybe they experiment with smoking and when they're in college or whatever. But because their genetics, they started off with a low risk. Their cup never overflows and they never get cancer.
Okay.
Some of us, based on our genetics, we were already born with a high risk.
Yeah.
And so it didn't take much for us to be exposed to environmental toxins, maybe be exposed to some secondhand smoke, maybe like my brother and I did, swim in water that was around the corner from the nuclear power plant,
Oh, Scott, really? Oh my. Oh gosh. Okay.
and then our cups overflowed.
Yeah.
And then we got cancer. That was how they explained genetics to me in the sense of who gets it, who gets cancer, who doesn't get cancer. There's even more research that's been done as far as, again, the role of diet and again, environmental toxins of maybe turning those genes on, or maybe it's more of turning genes off as far as telling the body to stop with cell proliferation or that sort of thing. But I thought that was really interesting how he explained that to us.
It's easy
So,
to understand too, you know?
yeah, well, it's a great visualization. And I really think, Joyce, I really think that's going to be the future of oncology care is if they can actually really truly get into our genes.
Yeah.
I mean, the perfect example that I see as a clinician is who develops chemotherapy-induced peripheral neuropathy. Like women will get Taxol, and that can cause neuropathy. Or individuals who have colorectal cancer, they get oxaliplatin, that can cause the peripheral neuropathy. Some people don't, they get a very minor neuropathy, just a
Hmm.
little bit of numbness or tingling in their fingertips and toes. And other people, it is full blown, their feet, their hands. And then as a physical therapist, I'm worried about they have falls risk if they can't
Yeah.
feel their feet. Our occupational therapists are saying, well, if you can't button your shirt or tie a tie because you can't feel your
Right.
fingertips,
Right.
but is that based in genetics? Based on how your body reacts to Taxol or how your body reacts to oxaliplatin. And so if your genetics, Joyce, if your genetics say, oh yeah, you're fine, it doesn't, you can get oxaliplatin and it's not going to affect you, great. Then you get oxaliplatin and you get that treatment. For me, if I've got some genetic thing that says, no, I'm going to have a really bad adverse reaction to oxaliplatin, then you don't give me oxaliplatin.
Right.
You give me something else.
Yep.
That's personalized medicine, and that's looking into the genes. And I think that that's really where our, oncology treatment is going to go in the next 5,
Yep.
10 years.
Yeah. I agree with you just a little bit. I've read about it in how you can target, like you just said, you can target the treatment to what you, Scott, or you, Joyce, need,
Hmm.
and I think it's cool. It's very nice
Yeah.
that hopefully we'll get there, so
Hmm.
Well, I also wanted to ask you about, I'm looking at some of the ideas I've had here. One of the articles I read that you had written, it was about now 20 years later and living with cancer. I'm going to read a quote from that article. I would just like your thoughts on it. And the quote is, while we may be living clinically with no evidence of disease, we live with the evidence of the history of our disease every day. Like petrified trees or fossilized shells, cancer treatments leave permanent physical and psychological reminders of our cancer experience. And you've kind of talked about that already, but can you add to that perhaps? So,
That was really the impetus of me writing the article, is because young adults, we get misdiagnosed or we don't get diagnosed because we're young and we're otherwise healthy. And so a lot of times, by the time the diagnosis is made, it's a stage 3 or it's a stage 4 cancer. You don't just assume to find testicular cancer or breast cancer or colorectal cancer in somebody who's in their 20s or 30s. And obviously that's what we're seeing with
yeah,
trends now. And then even after treatment, our hair grows back and you can't see our scars. So
right.
on the outside, we look fine. But inside, we know that we have physiologically aged because of treatment. Our bodies have had to work hard to rebuild themselves
Yep.
after surgery. Our bodies have had to continue to work hard to rebuild ourselves after chemotherapy and after radiation therapy. And and chemotherapy and radiation therapy can leave these permanent adverse effects on our bodies as far as weakened bones, tight tissue, again, issues with our cardiac system, damage to the heart, damage to the lungs, damage to the kidneys. It's been well documented in our pediatric population that chemotherapy at a young age can affect cognitive development. So these things we live with for the rest of our lives. And especially as pediatric survivors and AYA survivors, will have decades of life ahead of us. But that means we have decades of life to have to manage these late effects.
Right.
And, we talked about the fertility one. You can't tell from looking at me that I've had fertility issues. You can't tell by looking at me from the outside that I now have pulmonary issues. Just like I can't tell with a lot of my patients that I see in survivorship, I don't know what's going on with their heart. I don't know what's going on with their range of motion until I start diving into it.
Right. Right.
So, so that stays with us for the balance of our lives. And obviously, we're grateful to be alive. It's just that I think the medical community generally, as well as society, but I was really writing this from the perspective of increased awareness for healthcare providers that when you see cancer in somebody's chart, you have to be able to ask those pointed questions. You can't just gloss over that and say, "Oh, they were diagnosed with cancer 20 years ago, and now they're standing here in front of me and they look fine." So, I'm not going to ask them any questions about that.
Right. Right. No, you're right. You're absolutely right. Gosh, it just makes me think about some of my history too. But so, what's next in life for you? In your career or personal life or anything you want to talk about with us? What's next?
This year has been an incredible year of growth for me, Joyce. I've been very fortunate that I've been able to advocate for rehab for our cancer patients and our cancer survivors. I've been able to present conferences to talk about the needs of physical therapy,
Right.
which is great. This year, I had the added honor, which was pretty humbling, but also really necessary, that I gave a couple of talks as the patient advocate,
Okay. That's
speak,
great.
speaking at medical conferences as the patient and not as the provider.
Okay.
And it's taken me, over 20 years to find that voice. I found the voice of the professional, you know, beating the drum of oncology rehab and how important that is. I found that voice first, and I've always been an advocate for survivorship, but now to do it on that level has been really eye-opening and really makes me understand that for those of us that do have a lived experience, it almost is our responsibility or our obligation to get in front of these medical providers to say, you have to listen to your patients. You have to make these shared decisions with your patient. You can't just blindly do the shotgun approach, give them this treatment, and then be done with it. Like, you have to factor in quality of life. You have to factor in who that person is. Does that person have little kids at home? Is that person still in school? What does that person do for work? All that needs to be factored in
Right.
to that. And so I think professionally, where I want to continue to grow is to obviously continue to advocate for oncology rehab, within my own profession and then within the oncology profession generally, to make sure that oncologists and surgeons and rad oncs are sending these patients to rehab, but also continuing to work as a patient advocate,
Yeah.
to use my lived experience as proof that, we're not necessarily otherwise healthy.
Yeah. That's great. There's a place for that. I know, like you mentioned, the conferences you've been to. My career, a big part of it was in health IT, PR, and communications, and adoption of electronic health records. But patient advocacy became a big part of the conference that we hosted, and just the discussion of what, as you said, the medical profession needs to hear from patients and what's going on with them. So I applaud you for doing that. That's wonderful. So my last question is, what song, when you hear it, do you have to sing along?
Oh, there's a lot, and I can embarrass my kids with a bunch of them. I am a child of the 80s, so Pour Some Sugar on Me by Def Leppard is always a good one. Living on a Prayer by Bon Jovi is always a
Okay,
good
yeah,
one.
yeah.
If you reframed the question a little bit as far as like, what is your walk-up song? Like, the baseball season just ended, so anytime somebody goes up the bat, they're playing a little
Right.
clip for music. I think my walk-up song would be LL Cool J's Mama Said Knock You Out.
I like that. Oh, that's great. Mine would be Twist and Shout by the Beatles. So that's my
Oh,
era. This has been great, Scott. I think you've opened up a whole area of discussion, at least for me, with testicular cancer, and I think our listeners, about the importance of physical therapy and that should be part of your treatment and care. So I'm just glad that we had a chance to talk and you could share all that with us. So,
yeah. Well, thank you. Thank you for having me, and thank you for doing this podcast. So again, to elevate the importance of testicular cancer and how important it is, through treatment, through survivorship, and all of it.
yeah, yep. Takes all of us to get it going and raise awareness. So, but I hope maybe down the road you'll come back and tell us more about what you're doing and what's going on with physical therapy. It's just fascinating, I think. So thank
Yeah,
you.
that'd be great. Thank you.
Thank you for watching this episode of Don't Give Up on Testicular Cancer. If you enjoyed this podcast, please subscribe to our program on your favorite podcast directory. You can also visit the Max Mallory Foundation at www.maxmalloryfoundation.com/podcast to listen to previous podcast episodes or donate to the foundation. Join us again next time for another episode of Don't Give Up on Testicular Cancer.